Good afternoon, everyone, and welcome to Wednesday Wellness, a free live educational series by Trinity Health. We are thrilled to have you join us as we discuss this important topic of the caregiver experience. Before we get started, we would like to share a few notes. Your cameras and microphones have been turned off to ensure a smooth experience. If you have questions during this presentation, we ask that you please use the Q&A chat feature located at the bottom of your screen. Those questions will be addressed at the end of the presentation. Lastly, today's webinar is being recorded, and a link to that video will be sent to you via email over the next couple of business days. And without further ado, it is my pleasure to introduce today's presenters. From our neuroscience team, we have nurse practitioner Susan Price and patient and caregiver support coordinator Susan Woolner.
Thank you, Brittany. Thanks for introducing us. One other thing I wanted to mention is that I also am a health navigator for the Alzheimer's Association and a community navigator. And I think that is what our topic is about today. So I wanted to make sure I mentioned that. Here's our list of things that we're going to go through this today. Support and strategies for managing caregiving of someone with cognitive decline day to day. Helping stress. I mean, one of the things that I know, One of the things that I know that is important for everyone is coping with stress and self-care, maintaining caregiver health and well-being, and addressing resources. The practical tips that we provide are ones that can change for different people. And so one of the things is checking with your caregiver as well, with your care provider as well. And we only have 25 minutes, so we're going to be quick in going through some of these things with time for questions at the end. And there will be a resources guide that will come out with an email, probably the link to the presentation. So thanks so much for joining today. So who are caregivers? Many of us are caregiving, whether we consider ourselves caregivers or not. Nearly 12 million Americans provide unpaid care for family members or a friend with dementia. This is an estimated contribution to the nation value of more than $413 billion. The average number of hours of care per week that is provided by people for someone with dementia is 31 hours. So if you feel a little bit overwhelmed, it's probably because it feels like you have two full-time jobs, and then maybe you're splitting your time with caring also for somebody who is a child, or you care for other family members who have children. So it is a very intensive caregiving situation. This is a list of 10 absolutes for dementia caregiving. It's been around for about 25 years. And I share this because one of the times when we provided it this is now 10 years ago at one of our support groups, one of the caregivers said, it feels like I'm doing things wrong, the way it was phrased. And while these are good advice and good strategies, I think never reason with somebody with dementia is one of the ones that I think goes through people's head. It is not really the best for your person that you're caregiving for, or there may be better ways. And we're going to go through those today on what are some of the ways that we can phrase some of these things and actually choose our strategies based on the person that we know. So first, primary care physicians play a vital role in early detection and diagnosis. And really, they are a first stop for many people who are looking for care. They are our resource for all stages of the disease and progression. They often have social workers in their primary care offices that are helpful as well. They are central to the collaborative and coordinated management of dementia care, despite the age, the level of care that they need. So I wanted to make sure that we put that in the resources. If you don't have a caregiver, a primary caregiver that is somebody who is helpful for you in this journey, I want to make sure that that's something that you think about and look for somebody who is that caregiver. So here we're digging into the meat of really support and guidance for caregivers. And I'm going to let Susan jump in on some of these, but really I wanted to introduce using a person-centered approach. So that sounds complicated, but really it is what you know about the person you're caring for in order to provide the best care. So if your person is somebody who has a lot of friends, probably a social individual, and so using that knowledge of what you know, or maybe the job that they had, or kind of their interest, allows you to use the strategies in order to be able to like distraction or involving them in the independence thing. In order to do that, using what you know, and I suggest that families, when they come to one of my support groups, um, write these out, because there may be things that you can add to the list as you go of, oh, I forgot that that's something interests them. If their interests have changed, that's also something you need to document in order to make sure you're going with the interests they have now, where they are on that caregiving journey. Encouraging independence as you go will make your life easier as you get on this caregiving path and their independence starts to diminish. So, somebody who you're doing everything for, that they could do things for themselves, even if they're not doing them exactly the way you would, is important. So, knowing that you need to encourage that independence along the way. And I'm going to let Susan jump in on the balancing safety and independence, because I think this is really critically important as stages change.
Yeah, this is always sort of a tough thing for caregivers, because a lot of times in early stages of dementia, people are still very independent. And so there's a lot of gray areas when something might become unsafe. That includes things like driving. So I actually have folks very early on in their diagnosis of dementia that they're still able to safely operate a vehicle. But it's always tricky to know, well, when is that line where this is no longer safe? And so that's a lot of it requires oversight from a caregiver, which can be really exhausting. But I encourage people to always ride in the vehicle, see how they are managing and approaching traffic. Sometimes, if there's a lot of mood related issues, impulsivity, then that might be a time where we discuss stopping things like driving. But the other thing that can be a big safety issue is time alone in the home. So making appropriate decisions. And so getting a lot of that information out to your care provider, whether it's your primary care provider or whether you're seeing someone here in our neurology clinic, we'll try to ask more focused questions. But having some examples of things that might be going on in the home can also help us to guide those safety decisions for you too, because it is really hard. And as Susan mentioned, we want to try to keep people independent and able to do things. There's a lot of self-worth that is attached to our independence. So most people still want to feel useful around the house. Like you don't want to feel like you're just waited on or you're not allowed to do things. People want to help. They want to contribute. And that's an important thing for self-worth too, which is why maintaining independence as much as possible, as long as it's safe, I think is important.
I think that the time alone is important. I think that also that independence. I remember a caregiver who brought something to our support group where the person she was caring for would say, "I still have free will," and I think that free will of the ability to do things on their own, just picking and choosing the things that you want to encourage independence on and allowing them to do them. And again, even if it's not exactly how you would do them, it's important. But the things like managing their own medication and other things sometimes change over time, and knowing that you might need to monitor that. I think one of the important things is focusing on reducing stress between couples. So I think driving is one of those things that will, if somebody has always been the driver in the family or in the couple, that's a difficult task in trying to switch that to somebody else. And there's a lot of times where you're not driving the way they may want you to drive. And so that's sometimes stressful. And there's adapting to the changes in the relationship between the person you're caring for and yourself. I think that those are a lot of times the things that we need to really focus on and decide what are our things that we're going to be absolutely critical and important about making sure we do, and the things that we can let go. And so again, these strategies of the 10 absolutes for dementia, I think that letting things go are some of those things, as long as they're not things that are safety issues or things that are about that self-care. Communicate about care decisions. And Susan has some really great advice on this, really on building a team that works for you and how to communicate those care decisions across time as the disease progresses. Susan, you want to take it?
Sure. So, as a provider in our memory clinic, it can be really helpful to prepare for the visit. And sometimes people don't, and I try to ask very focused questions to try to get a sense on how things are going at home. But a lot of times there have been some things that are going on that are really important to bring up from your perspective. Perhaps there's some behavioral concerns or changes, cognitive changes where you're needing to help the person do things more often, such as like medication management, like Susan mentioned. So like before they were able to independently take their medications, now you're needing to set them up in pill boxes for them, or maybe now you're actually needing to physically give them to them so that you know that they take them appropriately. All of those things are really helpful to kind of make note of so we can bring up at the appointment. There are also some things which might be difficult to bring up in front of your loved one, especially if there's behavioral concerns, because we really want to be respectful of your loved one's dignity, that if it makes them feel shame, or perhaps they're not even aware of these behaviors after the fact, but it's affecting their well-being and your well-being, or maybe it's a safety issue. It can be really helpful if before the visit, either call the office and sort of give a heads up and just say, these are the behavioral things we've been noticing. I want to make sure that my provider knows that ahead of time, because this can be difficult to discuss in front of the patient. Or my chart visit or my chart message to me before the visit can be helpful. And sometimes that helps me to prepare, knowing, it might be good if we separate and maybe I have my medical assistant take the patient to a separate room so I can talk to the caregiver alone. So sort of knowing those things ahead of time can be really helpful for your provider, whether it's your primary care or someone within the neurology office as well.
I think people on a team that works for you are also sometimes people that we often don't think of as part of our team. Is it absolutely necessary that you go to the pharmacy to pick up the medication? Can you have it delivered? A lot of pharmacies do deliver. Thank you to the pandemic, and we looked for other ways. Picking up food. Are there things that you can modify or have friends do, and really putting together a list of people who've said, hey, if you ever need anything, I'm here to help you. Making a list of those people's names to be able to call on and say, hey, here's what I'm that's ahead of me. Is this something you could do for me? I am not able to do that, or I have to do this instead, in order to be able to think of those team members. And these could be drivers, they could be people who do gardening, they could be people who come in to maintain the house, it could be people who come in to do some of the cleaning because you just haven't been able to get to that, or you're going to take your family member out to do something that is fun and provides them an opportunity to have outside time, but also be involved in other things while this other thing gets done. And so thinking of those things and really thinking of who is on your team, and that might change over time. Sometimes people are not full-time team members, but they're people who you rely on for those things. And also people like in-home care, who you can introduce earlier in order to get the family member used to somebody coming in to do things other than yourself. So discussing medical and non-medical strategies for behaviors is one of the things that Susan works on a lot. I'm going to let her cover this, but really there are some times when they're at different stages of dementia where your doctor, working with your doctor to understand the options for these strategies will really make sense. Caregiver training and support is one of those, and I think this is what we're doing today. But beyond that, those changes that happen over time, the medical management piece is really important. Susan?
Sure. Yeah. So, this is probably one of the things that I see most often. There are times where a lot of these behavioral changes can be managed with reassurance and redirection. A lot of times there's a trigger for a change or a behavioral response. Maybe there's a change in environment or a change in routine. Susan and I actually were talking about this prior to our presentation about what a big difference the time change and getting so dark earlier can really make on someone's routine and sleep cycle. And those things can add to some anxiety and agitation. And a lot of times there's some environment changes that you can modify that might help with that too. I think what's really hard is when people start to get really anxious in the evening. Already as a caregiver, it's been a long day and it's hard to be patient and work on all those redirection techniques. Now, a lot of times when we're talking about adding different medications to help with certain behaviors, usually I first like to see, is there any other changes that we could make before we look at medications? But sometimes a medication is necessary. Usually my trigger is if we've kind of ruled out any other changes, they're not sick, there's not been these big changes. We've worked on reassurance techniques. This is a caregiver that knows this person really well, and this has been a clear change over the last few months. The medication is usually added if it's a symptom that's really affecting well-being of the patient. So, because when you feel physically upset or tearful, or anxious throughout the day, that's a really distressing symptom. And a lot of times we look at medications such as antidepressants, which might have less side effects, that might sort of calm that irritability or that anxiety and allow them to then have an improved quality of life. Because like I mentioned, those feelings, to feel that way or anxious or nervous or upset or irritable, are not comfortable feelings for your loved one either. So those are the different approaches. A lot of times part of our team, sometimes they'll send out home care nurses that can kind of reassess the behaviors and see them in their own environment. A lot of times when people come into the clinic visit, in this controlled environment, they're not exhibiting those sort of upset feelings the same way. They kind of hold those feelings in. And so I believe that those actually exist, but sometimes it's hard for me to see. So it's important for the caregiver to be able to verbalize those things. And then I could send someone out to the home to maybe help me make adjustments to medications if it's still an issue.
I think one of the other things that sometimes I've had a caregiver say when they go to the clinic that there's performance. It's not how they are at home. So because they're their best self in front of a provider, then that performance obscures what the caregiver is talking about. And so it is important, but safety issues, safety of a caregiver, safety of the person who they're caring for is the most important. And especially if they're care issues. Those are things we want to make sure are told to the provider ahead of time in order for them to really understand that and maybe send somebody out ahead of time in order to be able to see those in order to make the care visit that much more important.
Sure. Aggressive behavior is something that we want to address right away for the safety of both the person with dementia, but also the caregiver too, and coming up with a safety plan for them, because the safety of the caregiver is really important.
So We talked about a little bit about one of the other things that we can do is kind of exploring care services in the community, and planning for their future in order to make sure that you have a plan for not just now, but for what's maybe coming. And we don't know what that is. And it may be something that doesn't change much from what it is now, but ensuring your loved one receives the best possible support at every stage is important, but also that you receive the best support as the caregiver, and that your needs aren't overlooked. And I mean that from the bottom of my heart. Of a lot of times as a caregiver, and I've said this to caregivers, and I've had this happen to myself, is we delay care for ourselves. We skip our appointments because the appointment and the things we're doing for somebody else are more important or time sensitive. And when you're under stress, your body produces a chemical called cortisol that makes it hard for you to recover from injuries when you have a lot of that stress in your body. And so we don't want you to get hurt. We don't want you to overdo in the point where you can't recover from some of those things. Your care is just as important. So how can we make plans in order to do that? And again, support programming like you're on right now, social workers from the Alzheimer's Association, being able to talk to them. And the next slide has a direct number for you to get a 24/7 support from the Alzheimer's Association, but social workers within the clinics that you have. Susan has social workers within her clinics, and they can help look at kind of what's going on, but also understand from your perspective what are some of the things in order to suggest other solutions, like talking to a community elder care advisor who can suggest either adult day programs or start looking at care outside the home. Adult day programs are interesting because during the pandemic, they were often not allowed to stay open because of the close proximity to other people, and people who have dementia sometimes couldn't keep a mask on. And so there was a lot of navigation that people were doing. Most are open again now. There were some that in our area in Grand Rapids closed, but I know that when I talked to Sandy, who's one of the social workers in a clinic over here on the east side of the state, most are open now. And the adult day programs are both at a center that you can get the care at, or planning your own adult day program. And so this is where a different hat that you have to put on, where you plan to have somebody come in and oversee them as part of the navigation of maybe their PT or OT. So you have an activity that you're planning in order for them to be able to get that care at home, for you to do some of the other things you need to do, like provide care for yourself, or like doing the grocery shopping, things like that. Respite care is one of the things that a lot of times we don't think about firsthand as a caregiver, but it can be essential. And so I'm going to have Susan jump in and talk about respite care, because I think that that's one of the things the social workers recommend, especially when a caregiver is overloaded.
Oh, sure. Well, the respite care can be helpful in a few different situations too. Like I have some patients that they're at the point where they can't travel. The environment change is too much and overwhelming. And it can be hard for the caregiver, especially like, let's say you have grandchildren across the country and you and your loved one cannot travel together without it being an overwhelming experience. There are respite care options where perhaps your loved one goes to like a nursing care facility where someone can oversee their medications while you leave for a period of time. But respite also can be someone coming into the home. I actually recommend this fairly early on, is if you're able to manage that financially, because Medicare will not cover this, unfortunately. But even having someone come in a couple hours a week where like, oh, on every Monday, I can go have lunch with my friend, or I can run errands and feel confident that they're safe at home, or I can set up this appointment and not have to bring my loved one with me. Just some time where I know that they're safe and I can be free and not worry can be really important. And that's sort of what the day program does as well. So, day programs are actually a center where you would bring your loved one for a full day or a half a day. And they are used to, it's mostly people that have some sort of cognitive diagnosis, mostly dementia, and they get medical care provided and they're in a safe environment with workers that know how to interact with those and redirect and reassure people that have dementia too. So utilizing those resources early on, because what happens, I think, as a caregiver is as dementia progresses, you start putting more and more on your plate. Well, maybe before they could empty the dishwasher and now that doesn't work out anymore. And so running a home as well as providing care, your plate just starts piling up. And it's not that you're not doing a good job completing all those things, it's just that you never get a break from those things. So if you can figure out how to carve out some time, that will be really important for your own health and well-being too.
I think that respite care is also one of those things that people think my family member isn't going to allow somebody to come in the home. And I think in every situation where a caregiver has told me that, and once they finally test that theory, um, it has gone well. And now that doesn't mean that the family member doesn't say, you know, I didn't like that person at the end of the day, but you can observe them and they're actually in conversation and seem to be doing well. And so it really is something that a trial and error in order to make sure that you, one, have the right person coming into the home, but also that they're providing the right level of support for the things that they really need to do, and for your own home. And so I know that it's hard to have somebody come in the home, but I also think that understanding that that might be the next level of care and provide a level of support that you maybe didn't think possible for your family member. So really trying some of the things in order to see whether it will work. And the last thing on this list is palliative care, or hospice care. And Susan is excellent in talking about palliative care because that's one of the areas where she works. But the difference between those two, I think, are misunderstood. So, Susan, could you describe that?
Sure. So palliative care is mostly supportive care. So when we see people in our neuropalliative care clinic or palliative care in general in the community, their goal is to follow someone with a chronic illness. And a lot of it is symptom management, but also support. So we kind of overlap in our memory clinic because we do a lot of those services as well. But also some of it will help us prepare for the future too. So we talk a lot about making sure things like advanced directives and in the wishes of your loved ones, all of those things are kind of set up, those ducks in a row, so to speak. It can be really helpful to think about those things early on as opposed to a reactive thing because something happened and now we have to quickly make those decisions. So we encourage people to sort of consider those things ahead of time, and palliative care does that too. But mostly it's supportive care and planning. And then when appropriate, transitioning to hospice. I think what's really challenging with admission into hospice with a dementia diagnosis is really challenging. You have to meet very specific criteria. And so people with dementia can live for years with a dementia. And so it can be really hard to get admitted into hospice. But palliative care as another support in the meantime can be really helpful along with this journey.
Some places around the state also have a home service that provides palliative care, or other hospice organizations have palliative care that can be activated again through a primary care physician that will come into the home, but it's through the hospice provider, but it's palliative care. I know on the east side of the state, we have Angela Hospice that has a palliative arm. And again, it's working in conjunction with your primary care physician, and they're updated with the things that are going on with you in the home, but they can also help navigate what's going on, especially if there's other health situations. One more thing about respite care that I want to make sure I mention is respite care in a facility is something that Medicare often pays for a certain amount of care, but it also requires, it's not something you can activate tomorrow because it requires a health check and a screening. A lot of times making sure that the person has a chest x-ray so that they don't have something that bringing into the facility is going to make a difference on, and making sure that they're in the best health. So if you're interested in respite care, again, talk to your primary care physician and the social worker there in order to make sure that that's something you have those things done that you need in order to be able to investigate the next level of respite care and plan a weekend away that you can make sure your family member is taken care of, but also that you have done all the things in advance in order to make sure that it's something that you can do when you need it done. So this is Alzheimer's Association. Again, I'm a community educator for them. The 24/7 helpline is an essential thing. It's 800-272-3900. We have magnets with this on. If you are interested in those, I think the Alzheimer's Association will send you out a magnet with those on. Having that on your refrigerator, I have used this number and had to look for the number when I needed it. I didn't have it on my refrigerator. And I think that because it's staffed by master's level social workers and psychologists, those are the people essential that you want to be able to talk to when you're at a point where you're not sure what to do, or you are at a point where you're navigating from one stage to another and you want to make sure that you have guidance on what the next stage should be for you in seeking that care or those resources. And they are essential for that. No matter where you are in the country, they have an option of being able to search those resources in your area. They're extremely helpful. And I want to make sure that that's something that's a number that you have available to you at any point in the care process.
The only other thing I would mention with that too is that most people think, well, I can't call the Alzheimer's Association because my loved one does not have an Alzheimer's dementia diagnosis. They also help with other mild cognitive impairment and other types of dementia too for resources as well. So if your loved one, this is not their type of dementia, the Alzheimer's Association will still provide you support.
I also think that one of the things that they often say is, connecting that person with a support group. And there are support groups for people who have mild cognitive impairment now. I actually do one of them. It's the second Monday of the month. And the people who raise their hand to come to that are people who are trying to navigate the diagnosis on their own. They're not the caregiver. There is a group for caregivers as well, but I think that a lot of times there's individuals who have mild cognitive impairment and want to navigate the best way possible for themselves. They're being diagnosed earlier. And so it helps connect them to other people who are in similar situations as their own. And they can get advice from others, but also there's content we provide that help connect them to those resources as well. But certainly for caregivers, no matter whether you can't go to a group and you want to attend a group virtually, like Zoom, like we're on now, or whether you want to go to one in person, across the state of Michigan and elsewhere in the country, there are support groups that would be available to you. And they're manned by people like myself, where they've been through care situations and they are a caregiver themselves, but also they have sometimes multiple people in the group that have either gone through a care situation and now have said, don't do what I do, or don't do what I did. I think that the best caregiver that I had that attended one of my groups was a man who said, I thought, this support group was never going to be for me. And he was one of the biggest advocates for a support group because he really was able to see the resources that were available to him.
Not only that, I learn a lot from my caregivers. So I like to give advice, and sometimes I share advice that I've already learned from other caregivers on how to manage certain situations or different techniques. And so I think that caregiver support groups can be a really great experience too. Sometimes they're overwhelming for people, and maybe it's not your thing. But I will tell you that as things progress and change, there's often someone that's gone through something similar, and they might have some approaches that worked well for them too.
I really agree. And I think that support groups are something that I think that some people think support groups, they're going to see people at the later stages that it's not going to fit them. Really, support groups, especially for young onset diagnosis, I think that that's more challenging because there's other things that they may have still have children in the home that are younger, and they're trying a caregiver is trying to navigate that piece and what do they talk about with their kids. But I think all of those things are really important. And there is a shortage of caregivers. This slide really talks to it, and it came from the resources from the Alzheimer's Association and the Dementia Coalition of Michigan. Nearly 900,000 additional caregivers, care workers for people who would be care outside the home or care in the home that came into care for somebody are going to be needed for the number of people who are aging into that area. By 2032. And so they have projections that they have the number of people who may have dementia. And of course, they're just projections. But if you're a caregiver, you're one of a lot of people who are going through this. And we want to make sure that you get the support you need, which is essential at any stage. And that is our final slide. And I think they're going to open it up for questions. And hopefully there are some, but I would love to be able to support you. And I think Susan and I are have some additional time, and we're open to questions.
Yes, thank you guys so much. That was wonderful. As Susan mentioned, we are taking questions now. So if you have not had the chance to, you can use the Q&A chat feature, which is located near the bottom of your screen, to drop in your question. We do have a few that have already been submitted, so we will get started. And it says, the very first one we're going to start with is, what is the memory clinic and how does it work?
Yeah, so I'd love to talk about that. So our memory disorders clinic is part of our neurology center. So there are neurologists that I work with. We have one medical director, Audrey Sanders. So she gave a talk, I think, on one of these not too long ago. Right, Brittany? And so a lot of times it comes either via usually a referral from your primary care doctor. So as you probably have noticed, primary care, a lot of times you don't get as much time to talk about all the issues maybe going on. And if memory is starting to change, they might do a screening and then refer either to neuropsychology, which does a very large cognitive screen, or often to neurology to help find a diagnosis and then make sure that you're linked into supports. So in our memory clinic, sometimes people come to us already with a diagnosis. They've already had a workup completed, and we usually just review what's already been completed, and maybe we concur with that diagnosis, or maybe we do some additional testing. And so part of it is finding the diagnosis, but then the other piece, and this is often the folks that I often see folks in follow-up, and we do check-ins looking for we look at the cognitive changes. We assess kind of how the caregivers are managing, see if there's any safety issues that might be coming up and how to address that. We talk about future planning. And then sometimes there's physical changes that we want to assess for too. So maybe walking's different, or balance or swallowing or any of those things. So it's really an assessment of all of those things. So the memory clinic is a clinic where we follow people throughout their journey, and then bring in other supports as needed, to make sure that we try to help support the needs of both the caregiver and the patient as much as possible. I don't know, you have anything else to add, Susan?
I would just say that one of the things that I think the memory clinic does really well is assessing whether the caregiver is in a position where they maybe have medical needs of their own that they maybe have not addressed. And that's a hard conversation, but I think that our memory clinic is very good at saying, I think we're at this point where we need to do something like, and whatever that fill in the blank is. But I think you're very good at making sure that that caregiver is well taken care of as well, and being frank with them on kind of what stage they may be at.
Yeah. Well, and the caregivers, golly, it's such a journey, and it can be rewarding, but it is a really hard job as a caregiver, right? And it's often not one that you expected to take on. It wasn't part of maybe your retirement plan. Um, and so I often will see people come in, and almost always the patient, the person with dementia, is well taken care of. The person I worry about more is often the caregiver. So it's not usually the patient, like I mentioned, that I'm so worried for. And it's a diagnosis that affects both the caregiver and then the person that has the diagnosis. It just affects them in different ways. And so it's really important to look at both people or more if sometimes there's multiple caregivers. Um, and so that's just an important piece too when you come into the clinic.
Thank you both very much. And we will include that previous webinar that Susan mentioned in the follow-up email if you'd like to take a look at it. Our next question, I think you may have touched on this briefly, but this one is saying, my mom who has early stage dementia and my dad who does need some support. I'm not sure where to start. Who do we reach out to, and how do we find out what services might be covered by their insurance?
You want to start, Susan?
Yeah. So first of all, I would say, talking to the primary care physician to see whether there's a social worker there that can maybe help navigate some of those things. And I don't know what the other health issues are for your mom, but I think that understanding, making sure that they have documented that your dad needs some help as part of, them seeing your mom. I think that that's one, kind of raising that awareness that there is a condition that, we're going to need to watch and look at. I also think that the Alzheimer's Association is a good first place to look. One, they have a list of activities that people can do, both virtual as well as in person, of meetups and things like that, that are social things that you can do. There's also a dementia cafe. So being able to go to a time when other people who are with dementia there, who, if they want to talk to them about that, or even if they don't want to talk to them about there, you're in a safe situation where people already know about memory issues, and it's a safe place to be able to be yourself. I think that support groups are a good place to look, but I also think primary care being that point, whether you've been referred to a memory center or not, is being able to have them connect you to some of those things that may be good. Also, deciding what your mom's likes and dislikes are, and how much support, whether your dad needs support with doing things with your mom, or whether he needs support outside of those things. So kind of his independent support needs, or whether there's support while he's caregiving. Because I think those are maybe two different things. And that support might be something that he needs support on his own for the things that are going on with him, separate from the support he's providing your mom. Go ahead, Susan.
Yeah, I think that the other thing I want to bring up, and a lot of people assume that Medicare will pay for in-home help. And the type of in-home help it will pay for is usually a temporary thing. Like, let's say after an office visit, I see someone and I order in-home physical therapy or nursing. That won't be a long-term thing. And so we have two really amazing social workers. I feel so lucky to have them as part of our neurology clinic that do know some local resources. Sometimes there's some grant monies. If someone qualifies for Medicaid, often we can get some additional insurance covered help. But Medicare itself, I think most people assume that they would help pay for like continued long-term support. So we have to look at what other resources are available. Sometimes people have money to use private pay, and there are lots of different agencies that our social worker can help sort of get people integrated in. But they also look at other supports, like perhaps someone's a veteran and there might be some VA benefits. I have people that have taken out long-term care insurance policies, and I can help fill out those forms so that we can start getting some in-home care too. So it's looking at other avenues, especially if finances are an issue, to see if we can have any other support. So that's why I really utilize, we have a great multidisciplinary clinic with our social workers and our therapists that can help us find as much resources as possible to help get some support for our, your loved one too.
Thank you very much. Our next question is, my mom has dementia and lives with us. She refuses anxiety medication and avoids social activities unless someone from the household attends with her. What are some realistic, non-medication ways to reduce her anxiety and help her feel secure and purposeful without over-relying on me?
Sure. That's a great question and really tough. So as people have progression of their cognitive diagnosis of their dementia, a lot of outside the home, outside of your normal environment situations can be anxiety producing if you don't see that stable, comforting person by you. Sometimes we see this even within the home where people can exhibit what we call shadowing behavior. You want to be close to the person that makes you feel comfortable when it's getting harder to navigate the world on your own. And so in those types of social situations, socializing is great for the brain. So I applaud you for wanting to consider those things too. What I would recommend is going to these events with them and then trying to pair up with someone who they start to feel comfortable with too. It won't happen immediately, but a lot of times, if this is an activity that includes other people with memory impairment, and some of the people running it also are good at working with people with memory impairment, they can kind of help integrate that in. And so then you might be able to slowly sort of back away as the routine and comfort occurs with that. The other thing to keep in mind too is I have some people, and I don't know what her personality was prior to the dementia, is I have some people that always felt more at peace not in big social situations. Like those were overwhelming even before their dementia diagnosis. And so if the expectation wouldn't necessarily be, well, now they should be able to manage that too. So sort of knowing their personality, that maybe you need to think of another option other than that socialization, because maybe that's just not something that would work for your loved one.
I want to also mention that there's sometimes, in my own experience, when there was a refusal of some medication, the caregiver said, this is the medication is important for you to take because I need the help with some of the things that are going on. And the doctors discussed this with us, and they think that this will provide some support where, you feel you're getting anxious or, turning down that anxiety. I think sometimes it's how it's delivered, and also the time of day that it's delivered. If they take their pills in the morning, there tends to be a lot more refusal in the morning. If you switch it to the afternoon, where they're a little bit more worn down by the day, they are very accommodating to taking that. So sometimes it's the time of day that's done. I also think that there are things like music. So music therapy is one of the things that we know decreases anxiety. And I think that those are things that often aren't thought of. And so that's a non-medication thing, that using music from their era, music that they loved, helps de-escalate. And also it can be continuity from doing one thing at home to that music doing another thing another place. So the music remains the same, but allows them to transition to something else by using the music.
Thank you both again. All right, our next question. We do have a few questions about support groups. We will definitely make sure that we include this information in our follow-up email, but so I'm just going to touch on a couple of them. And this one is asking about support groups specifically in Oakland County.
Okay, so the resource I'm going to be sending allows, well, first of all, you can call the 800 number, 800-272-3900, and they can connect you to resources in Oakland County. There are several. Again, as my role as a community educator, I attend a lot of groups elsewhere in the state, in fact, all over the state. And I know that there are some, and I've been to some good ones in Oakland County. However, the resource I'm going to be sending you allows you to look at, is it in person or is it virtual? Is it the time of day that you can actually get that, go to a group that you need a specific time? The 800 number can help you kind of zero in on that time, but this also will allow you to use your zip code to search ones in your area. If there's not one in your area, all the more reason to call the 800 number in order to make sure that they know that that's an area that we need one in your area. And there are areas of Michigan that I have found that don't have groups. A lot of times they will match you to a group that's virtual. They'll meet your time of day. And a lot of people say, well, I don't understand what a virtual group will do. As somebody who converted our groups to virtual during the pandemic, and some of them are very successful groups, we provide the same level of care and the same people coming to see the people that are there, just like a group in person. And so if you haven't been to a group and you're thinking, I wouldn't want to go to a virtual group, it's just like we're doing here. It's you and I talking to each other and other people adding in things and sharing their resources. So consider that as an option.
Thank you so much. And as a reminder to everyone, if there was any part of the presentation that you were not able to listen in on or may have missed, we will be sending a recording, so you will be able to watch that back. We have a few more questions to get to. One is mild cognitive impairment diagnosis different from a stage of dementia, or is it part of the progression of dementia?
That's a great question. So, mild cognitive impairment is a diagnosis on its own. So, depending on who you talk to, or if we're looking at research reasons, sometimes they will include that as like an earlier stage of dementia. But the diagnosis of mild cognitive impairment does not automatically mean that this will progress into a dementia. There is a higher likelihood that it will, but it is not something that absolutely this will turn into dementia. So the patients that I see with mild cognitive impairment, we usually check in every 6 months and do some more cognitive rescreening. And we're looking at different progression. And then a lot of times it's lifestyle modifications that we use overall for brain health. And just getting a good history from the loved one and the patient themselves on what symptoms that they're noticing. And so in clinic, we usually separate that from dementia itself. The term dementia is a really broad term. It essentially just means that people have enough change in their cognition that requires them to be dependent in some way on someone else, meaning they can no longer manage the finances of the home. They're not able to pay the bills because of their cognitive problem, or they cannot manage their medications anymore because of their cognitive problem. They cannot meal plan because of this cognitive problem. So it means that there is a dependency. It does not tell the type of dementia. So Alzheimer's is the most common type of dementia, but there's lots of other types of dementia too. So dementia is, like I said, just a very broad term, meaning there's dependencies. In mild cognitive impairment, there's not any dependencies yet.
I think also the brain health piece is one of the things we talk about in the group for people with mild cognitive impairment is what are some of the things is really, again, maintaining their independence, but what are some of the things that prompted this diagnosis of MCI? And then are there things like organizational management or memory remuneration so that it helps them organize the organization? Or does it mean that they need to de-escalate the things like the number of things that they're doing that are now stressing them because of the number of things they're doing? Is it a loss of job? And so sometimes those go hand in hand with changes in an area of the brain that also are relating to other people. And so do they need a different type of job that actually doesn't require them to be meeting people? So there's all those things that go into it, and really working with somebody like Susan in the memory clinic, but also I think they do a good job at this at primary care. I think the job loss part is often the part where primary care says, not really great at this, but I think that coming to a support group might actually help, because we talk about those things in group, and you hear what other people are doing. Are they having to change that they were running a big company and now they're running a smaller business in order to provide money for themselves, but also it's not having number of employees that require a level of consistency and oversight that they can't do anymore.
Thank you. We're going to try to get in a few more questions as we're getting close to 1 o'clock. The next one is, can you please speak to alcohol use in the dementia person and encouraging cessation?
That is a really tough one. So sometimes that depends on how long they've been consuming alcohol and how much. If there's a large amount, you actually can't immediately quit drinking. There can be some long-term repercussions from that too. Alcohol, the more we've learned about alcohol, we know that even small amounts probably isn't good for the brain at all either. And so ideally, having people cut down on their consumption of alcohol can be helpful. It's hard for folks that alcohol has been part of their routine throughout often their entire life, or adult life anyhow. So perhaps people would always have a cocktail prior to dinner. I don't tell people they have to completely cut that out if it's part of their routine, but often minimizing how much gradually over time can be helpful too. We know that alcohol affects processing, and so if you already have a brain that has a cognitive issue, it's going to impair that even further. Sometimes it creates some agitation if you just tell people you can't drink anymore. So figuring out a way to slowly minimize it over time. Sometimes people just kind of forget. I've also had some people switch over to like non-alcoholic beverages that have similar tastes. To sort of compensate for that. So they still have a sense that they're having a cocktail, but they're not having as many negative side effects from that. The other thing is too, is it's important to let your care provider, either primary care or neurology, know a bit about that. And we can talk about other techniques, and it might be unique to that person, or ways to reduce alcohol consumption if it's pretty heavy to begin with. But the other thing is sometimes there's some vitamin deficiencies that could also be adding to some of the cognitive difficulties that we should test too.
I am aware of at least one AA group that actually focuses on, and not everybody believes in Alcoholics Anonymous. I think it is helpful for people who want to do something at that level and actually change some of those things. But finding a group that has similar people in it, that where alcohol, they've had to make those changes in alcohol, and that they're supportive from peers that are going through it. Again, there is one AA group in Michigan that actually addresses that, and also the organization of that's run by people with dementia. And it's in Michigan. It's a national organization, but it's in Michigan. They sometimes have webinars on it, and I have sat in on those, and I think that that is a very difficult situation. Uh, Sometimes harder for the caregiver because it feels like, our goal doesn't match with their goal, and so sometimes, figuring out how those goals can meet and be common is one of the first steps in doing that, and saying, okay, here's what we can do. Let's decide on, as we go, what our goal is together.
Perfect. Thank you so much. Susan and Susan, it is 1:00 right now. Do you happen to have just a few more minutes? We do have a few more anonymous questions that were submitted that I'd like to get to. The remaining ones, I'm wondering if we could take those offline and have those addressed.
I do have additional time. I'm not sure about Susan's schedule.
I should have a few more minutes.
Okay. I will try to get through these very quickly. All right. First one is, I recently moved my husband to memory care for mild dementia and incontinence. Have you noticed that once in a facility, people are not able to move back home?
So I guess it depends on where they're at. I would say most of the time, the reason for transitioning to the facility is because it was too overwhelming for the caregiver alone at home. So, have I had people go from a facility back home? Yes. But oftentimes it's because they set up certain supports so that it wasn't just one caregiver caring for them in the home environment, too. So, I guess it really depends on the circumstances. But often the reason to transition to the facility is because their care needs were so great that they needed someone to move to that facility to have that greater oversight.
I have likewise seen the same thing. It doesn't always mean that they can't come back home, but I also think that the decision to place them based on whatever the decision was based on can be something that may not be able to be handled at home with the current level of support. And that's just saying that's a fact. And so if that fact doesn't change, then it's best for them to stay where they are, or, not maybe that facility or another facility. But I do think that if they have Alzheimer's, or, not just mild cognitive impairment, that level of incontinence is one of the things that's very difficult to handle at home, especially if it requires bowel incontinence and cleaning and things like that. That's very difficult for some families to handle. And I think that is one of the things that is kind of the line in the sand. I think one of our clinicians would always say, what's the line in the sand for you, to families, of when you cannot do this anymore. And if physically somebody can't do that, I would suggest they don't come home, at least to that home. Maybe they're another living situation.
Thank you. Next one that we're going to do is do you have any suggestions for redirecting someone that spends the majority of their day exit seeking, wanting to drive their vehicle once their driving privileges were taken away?
Yeah. Another good one. So I guess part of it would be helpful to kind of know if that's all they're doing all day. Are they trying to go someplace? Like, usually I try to figure out what is their underlying desire. Do they want to drive just to drive? That's a whole different situation. Or is it, there's something they really want to get from the store. So I think what can be really hard as a caregiver of someone with dementia is we really want them to kind of fit into our world and our expectations. And we actually need to kind of try to fit into their world and their needs, and kind of figuring out what those are. Obviously, if they're not safe to drive, you cannot let them drive. And sometimes that involves actually removing the vehicle from the home, making sure that you've got keys that they can't get a hold of, but then figuring out where are they always trying to go. That's usually the first question that I figure out. And then we kind of figure out ways to reassure and redirect based on why they keep trying to exit seek. Sometimes it's that the environment doesn't look familiar to them anymore and they want to go home. And that can be a tough one too. So oftentimes sort of like, let's talk about our home. Do you remember, even if it is the same environment, they just don't recognize it as such. What was your favorite part about the home? So it's a lot of different techniques, but I think actually knowing the underlying reason for elopement or what they're trying to get at can be really helpful too. Sometimes it's just pure agitation, and that's when we might actually need to do some medications or on top of just redirection and reassurance.
Yeah, I would say that sometimes it's anxiety, that over and over and over again is anxiety or OCD that really has been underlying for a while, and it just needs to be addressed with medical management. Um, Asking that, giving them a driver and saying you can drive, you can go. That person is going to take you where you're going to go, and a lot of times that doesn't mean they're going to go somewhere. A lot of times it's this is the ruse in front of that in order to that because they want their life to return the way it was, which is not really possible. Getting them involved in some of the things that they enjoy doing. If there's somebody who had friends, bringing their friends over. If there's somebody who wants to go to work or go somewhere specific, figuring out what that is. I agree with Susan in that figuring that might be the first question I would ask. I have actually dealt with that situation, and what we ended up doing for my family member was he wanted a set of keys in his pocket. It was his car, and he wanted a set of keys in his pocket. So we had a fob created that unlocked the doors, and he could sit in it, but it didn't have the controls that he could start the car, and he could carry it in his pocket. So we worked around that, and actually it did satisfy that immediate need of what he wanting and needing. We couldn't leave the other keys around because they would start the car. So those were things that we had to actually keep in a place that he didn't know about. But I think that those are things that figuring out whether there is a simple solution for what they want to do and figuring out if that will appease that level of anxiety they're having.
Thank you very much. And thank you for sharing that, Susan. This will be the last one that we are going to do. And then the remainder of the questions that we did not get to, we will address offline and include the appropriate ones in our follow-up email. And so that question is, my aunt is 94, has an Alzheimer's diagnosis. She has not changed much in the 2 years since her diagnosis. I have recently heard that new research suggests that people can stay the same for quite some time. Is this true?
It depends on the person. So if the diagnosis is accurate and it is Alzheimer's, we know that this will progress over time. The progression seems to vary a little bit from person to person, and it probably has to do a lot with other factors like other medical conditions. So we know that people with some uncontrolled diabetes or high blood pressure and those types of things, those other conditions can also affect cognitive functioning too. So, and we also know that it tends to people that have some physical activity and regular socialization, things might be subtle over time. So I've seen some folks for years in our memory clinic, and progression happens, but sometimes it can be really subtle from year to year, and sometimes it can seem like it can plateau for a while too. And it really seems to be patient specific. And I think a lot of it is also their overall brain health at the time of their diagnosis too.
I would agree. I also think that a lot of times the age, you didn't mention the living condition or living place, but falling becomes one of the things at that age that the progression is actually happening inside. We're not seeing it or measuring it. It's not something that we notice because it's not something physically that we interact with, but it could be weakness, and it could be something like that causes falls over time. And falls alone can be one of the things in dementia that causes kind of a downward arc of that level of ability. And so those are all things to watch. And maybe it's subtle enough that we're not noticing it, but it is something that, the care situation needs to have that oversight.
All right. Well, thank you both so much for your time today, as well as your wonderful presentation and the very insightful Q&A. We really do appreciate it. And to everyone that took the time to join us this afternoon, thank you so much for being here. And we hope that everyone has a great rest of their day.
Bye, everyone.